A lot of you have probably heard the term rapid sequence induction, but do you know what it is and why we don't always use it in anesthesia? RSIs are performed with the goal of preventing gastric aspiration into our lungs, and most people who come in for elective surgery have the time to be NPO or not take anything by mouth, so their stomach should be emptying when it's time to go through anesthesia and get intubated. Historically, gastric aspiration has been a huge contributor to morbidity and mortality related to anesthesia, and that comes from the hydrochloric acid reacting to the bronchioles, causing spasms as well as exudative reactions. And if a patient were to aspirate large particulate matters, it could block some of the main airways, causing distal collapse and atelectasis. The scenarios that we use RSI are for any time that we think a patient has a high risk for aspiration. These are going to include emergent surgeries, any surgeries involving bowel pathologies, any patients who have delayed gastric emptying or have an incompetent lower esophageal sphincter, patients who have an altered level of consciousness who cannot protect their airways, and also patients who are pregnant or who have neuromuscular diseases. I've broken down the sequence of events for an RSI into 10 different steps, but ultimately you want enough practice and experience of going through this so that when the moment comes, you can do it quickly without thinking too much about each individual step. Keys to a successful RSI include using a rapid-acting neuromuscular blocking agent, so that's succinylcholine or double-dose rock, having suction readily available, avoiding positive pressure mask ventilation, and letting go of cricoid pressure if it hurts your view.